So we're going to be doing a sepsis protocol review. We are updating our sepsis protocol that is going to allow us to give antibiotics to septic patients. So the purpose of this protocol review is to help us learn specific populations of patients that we want to give antibiotics to. So our objectives are we're going to go over the definition of shock, we're going to go over the different stages of shock, definition of sepsis, pathophysiology of sepsis, how to identify sepsis, and how to treat sepsis. This is a pretty straightforward presentation. I'm not going to go into, I'm not going to be too in-depth about any of these specific topics. So we're just going to kind of cut straight to the point, and that way will help us learn our new protocol.
So shock is a very interesting topic. Every single patient that we encounter that is really sick, whether it's from trauma or a medical cause, is in some form of shock. So shock is when our body has failed to be able to maintain adequate blood flow to our vital organs. If our vital organs are unable to obtain adequate blood flow, they are unable to obtain the nutrients in order for our bodies to create energy, specifically oxygen and glucose. Without the ability to create ATP, aka energy, your body has to switch to anaerobic respiration. Anaerobic respiration means that our body learns to create energy without oxygen. The problem is that the byproduct of anaerobic respiration is lactic acid. When you have too much lactic acid that builds up over time, you become acidotic. And your organs don't like a very acidotic environment. Remember, our pH should be between 7.35 and 7.45. Anytime our pH gets below 7.35, we become acidotic. Our organs will begin to fail. Increased lactic acid means decreased perfusion. Inside of a hospital, lactic acid is a good marker of how sick somebody is or how badly they are in shock. So a lactic acid inside of the hospital greater than 4 correlates with severe sepsis or severe shock, which leads to increased mortality.
Now when we look at the different types of shock, we have 4 different subcategories. Hypovolemic shock is essentially you don't have enough fluid in the pipes. Whether you are really dehydrated or you are bleeding out, both of those things fall under hypovolemic shock. Now distributive shock, you have 3 different things that fall underneath there. You have anaphylaxis, neurogenic, and septic shock. Distributive shock meaning that there is a significant amount of vasodilation occurring throughout the body that is causing a lack of perfusion. Now when we talk about cardiogenic shock, there could be a couple different things that fall under cardiogenic shock. A patient can be symptomatic bradycardia, symptomatic tachycardia, whether it's SVT or pulsing VTach, or they could be having a significant MI. All 3 of those things are going to hinder the heart's ability to perfuse and push out blood to the vital organs. When we talk about obstructive shock, there's also 3 things that fall underneath there. You have pulmonary embolisms, cardiac tamponade, and tension pneumothorax. All 3 of those things are going to obstruct blood flow and prevent the body from being able to perfuse its vital organs. So remember, shock is the body's inability or a failed circulatory system that has failed in preventing blood from being able to perfuse vital organs. That is very important, and the byproduct of not being able to perfuse vital organs is metabolic acidosis secondary to a lot of lactic acid building up. Now when we're looking at the stages of shock, you have 4 different stages. Your initial, your compensatory, your progressive, and your refractory. Now in your initial stage, you have very subtle changes as far as clinical signs and symptoms that you're going to be able to tell. The body has already switched from aerobic respiration, which is being able to use oxygen to create energy, to anaerobic metabolism. Lactic acid levels are already building up. As lactic acid continues to build up, your body turns to a compensatory stage where it's going to do everything it possibly can to maintain your blood pressure. One of the things that it will do is shunt blood to all your vital organs. So this is the reason why when you are initially presented with a patient who is in shock, the first thing that your body will do is shunt blood away from your skin, and which is why the patients are usually cold, clammy, and sweaty. Another thing that happens is it wants to retain as much fluid as it can in the pipes, aka your blood vessels, so it prevents you from peeing. So blood is shunted away from the kidneys, and we don't directly measure urine output, but inside of the hospital, urine output is a very good marker for how well the patient is being perfused. Because if they are not urinating, that is a bad indication that the patient is in shock, and the kidneys will eventually go into kidney failure if they go such a long period of time without maintaining adequate perfusion. Your heart rate goes up in compensatory stage, the strength of contractility, and your glucose levels. Now your body's glucose levels increase because they're trying to give you more energy to help you overcome whatever state of shock that your body is in. As you progress to progressive and refractory, the initial compensatory mechanisms that you see eventually start to fail. The patient becomes acidotic, they become hypotensive, they lose their level of consciousness, and if it isn't stopped in the progressive stage, they eventually will go to the refractory stage where it becomes irreversible and death will occur. So it's very important for us in the pre-hospital setting to stop this from progressing any further past the progressive stage. The earlier we recognize it, the better outcomes the patient has. Now, when we're trying to look at these different stages of shock with clinical findings, the most important thing that I want you to take note of is that the blood pressure is the last thing to go. So you notice in a compensatory stage, your blood pressure is normally normal. And the reason why that is if you look at the previous slide, your body is trying to do everything it can to maintain your hemodynamics. Okay, so we talked about the strength of contractility of your heart increasing, your heart rate increasing, blood being shunted to vital organs. So everything is being done to maintain that blood pressure. So just because your patient has a normal blood pressure doesn't mean that they're not in shock. It just means that their body is doing what it's supposed to do. The thing that you need to recognize is those subtle changes: the increase in heart rate, the increase in respiratory rate, the cool, the pale skin, the decrease in urinary output. Maybe the patient is starting to become altered and they're in respiratory alkalosis. Now, when we talked about in the previous slide the buildup of lactic acid causing metabolic acidosis, the easiest way that your body tries to compensate with acidosis occurring in the blood is with your respiratory system. You're able to make changes within seconds to minutes to adjust through the respiratory system the acid and base balance to try to balance out your pH. And so what I mean by that is if you have a lot of acid in your bloodstream, you will increase your respiratory rate to try to blow off as much CO2 as you can. Because if CO2 is allowed to sit in your bloodstream, it becomes an acid. So in order to get rid of the acid in your blood, your body will compensate by increasing your respiratory rate. So an increased respiratory rate, aka tachypnea, is an early sign of shock. That puts the patient in respiratory alkalosis. Now, as we look at progressive and irreversible, you notice that you have dramatic changes in your blood pressure, your heart rate dramatically increases, your urine output drops, and they go from initially compensating being in respiratory alkalosis to now being in metabolic acidosis. And once you go to that irreversible stage, they are completely dependent on event. They're completely dependent on pharmacology, vasopressors, and they're in profound acidosis, and their mortality rate has jumped through the roof, and the chances of them making it are very slim. So what is sepsis? Sepsis is something that you probably encounter on a weekly, if not daily basis. It's one of the more common things that we encounter due to the fact that we have a lot of nursing homes, we have a lot of older patients inside of group homes. All of these patients are in some form of sepsis, if not in septic shock. So when we think about sepsis, sepsis is a life-threatening form of shock. It comes from your body's extreme response to an infection. Now, when you have an immune response to an infection, your body is releasing chemicals to try to fight this infection. The problem is that when too much of these chemicals are being released and the infection gets out of control, these chemicals will actually work against you and cause systemic inflammation, which will eventually lead to tissue damage, organ failure, and eventually death. So When your body is initially encountering an infection, say a bacteria, it creates an inflammatory response. The inflammatory response is designed to bring as much blood to that area with white blood cells to try to help control that infection and prevent it from spreading. The problem is like I said earlier, if your body loses that battle with that infection, and that infection begins to spread to other areas inside your body and eventually becomes systemic, that initial local inflammatory reaction becomes systemic. And now your whole body is becoming inflamed. And that has specific direct actions on your blood vessels. Your blood vessels begin to dilate. Okay, when your blood vessels dilate, blood pools. If blood is pooling, it's not being pushed back to the heart. So that's going to drastically lower your blood pressure. On top of blood pooling, your vessels get leaky, meaning that they start to lose volume and leak outside of the vessels. So not only is your blood pooling, you're also losing volume inside of your vessels. And if sepsis continues to progress, they eventually will start to form clots inside their blood vessels. They go into what's called disseminated intravascular coagulation. So you have three things working against you in sepsis that is preventing adequate perfusion. You have the first one, which is vasodilation. The second one, you're losing volume, which is a form of like hypovolemia. And the third one is you start forming micro clots throughout your body. Eventually, as we talked about earlier, if it's not recognized soon enough and treated soon enough, organs will begin to fail, and when you have multiple organs failing at one time, the mortality rate increases drastically and the patient will more than likely die. So the key thing when you're learning about sepsis is you really have to understand SIRS. So SIRS is your systemic inflammatory response syndrome. Now if you look over on the left hand side, it has some vital signs and some lab values. Now later on in this presentation, we're going to go over CVFD's SIRS criteria. But the important thing for you to understand is that in order for you to call a sepsis alert into the hospital, you need 2 or more of the SIRS criteria plus a confirmed or suspected infection. If you have that criteria, which you can see in yellow, then you need to call in a sepsis alert. And the reason why a sepsis alert is so important is it tells the hospital, hey, I have a patient who is possibly septic, and I need you to allocate your resources towards this patient as the same way as they would if you had a stroke alert, a STEMI alert, or a trauma alert. Because if the longer this patient goes without getting proper treatment, the chances their mortality rate increases every single hour. So if you bring this patient in and they don't triage them properly and you don't give them a good patient assessment and a good patient report, and they basically pass this patient off into the lobby, you're not helping this patient out, you're doing them a disservice. So as we progress through the sepsis steps, you notice that severe sepsis is when their blood pressure is low, their lactate level is high, and they start having signs of organ damage. And if it isn't stopped at the severe sepsis mark, they will progress to septic shock, which is a persistent form of severe sepsis. So we have a thing called warm sepsis. And warm sepsis is essentially every patient that you've probably encountered that you've known or you have at least thought is septic, because you put your hand on them and you immediately feel that they are hot to the touch. And when you put that in context with the clinical presentation of the patient, you usually are leaning towards maybe this patient has some form of infection and maybe they're septic. Sepsis is the only form of shock where the patient will initially present with warm and flushed skin. Because if you think about every other shock, the patient is usually shunting blood away from non-vital organs, and they're usually pale, cool, and clammy to the touch. Now the reason why this patient in sepsis are usually warm and flushed is, one, your body's trying to respond to an infection by creating a fever, and two, all the vasodilation causes the patient to become warm and flushed.
Hypothermia in sepsis, or aka cold sepsis, can very easily be missed a lot by us, especially in the field. At community, we don't really check rectal temperatures. If somebody is cold and clammy to the touch, profound hypotension, we're probably more leaning towards another form of shock. The problem is that late stage of shock in sepsis is when the patient becomes hypothermic. The body has failed to maintain cardiac output, and this is causing the patient to be extremely cold to the touch due to the prolonged period of time of hypoperfusion from the hypotension that sepsis causes. So if you have a patient who looks septic and is cold, that doesn't mean that they're not in shock, in septic shock. It means that they're more than likely in the late stages of septic shock, and you need to move quick on these patients.
So when we look at serious criteria for our new protocol, what we've included in there is obviously tachycardia, tachypnea, but we also included a MAP less than 80. So instead of concentrating on systolic blood pressures, we want to concentrate on a MAP. And the way that we get a MAP is through the monitor has a little parentheses after you've taken your blood pressure, it will show you your MAP. So a lot of times in the ICU, instead of concentrating on systolic blood pressures, they like to concentrate and titrate their vasopressors based off of a patient's MAP. If you have a MAP above 60, you are able to adequately perfuse your vital organs. But we want to try to catch shock before they're already in that progressive, irreversible stage of shock. We want to catch them in their compensatory stage. So instead of lowering the MAP down to 60, we brought the MAP to 80. That way we can start treating these patients ahead of time instead of allowing them to get worse. Now, one tool that we're going to concentrate a little bit on in the next couple slides is end-tidal CO2. So end-tidal CO2 reflects lactate and mortality. So what that means is, as we talked about earlier, the higher their lactate level is, so a lactate greater than 4 inside a hospital, correlates with a really sick patient who possibly, if not treated quickly enough, has a really high mortality rate. Okay, so in our setting, since we can't directly measure that, we put them on the end-tidal CO2. A low end-tidal correlates with a high lactic. Okay, and that's something that we can get instantaneous. Lactic levels take time. They have to run a blood tube. That blood tube can take anywhere from an hour to come back. If they're using some point of care machine, almost like taking a blood sugar, that still takes time to come back. We have capnography, which is something that is instantaneous that we can use. So when we look at end-tidal CO2, we use this tool almost every single shift or every single tour. We have a good understanding that we need to use it for breathing problems, we need to use it during cardiac arrest, and we need to use it when we give pain medication. But do you truly understand how end-tidal CO2 can help you in multiple emergencies not related to just breathing problems, pain medication, and cardiac arrest? Or do we even understand why we even use it in those situations? Well, we know that end-tidal is very good at telling us how well a patient is able to take a breath in and out. If we have a high end-tidal and they're intubated, or we're bagging them, we understand that we need to blow off more CO2. Now, the other component of this is perfusion. Now, when we have a cardiac arrest situation and you have them on the end-tidal, a jump in end-tidal in a cardiac arrest tells us that their heart is restarted again. Well, why does their end-tidal jump up so quickly when we're doing CPR, and the CPR that we're doing is supposed to be adequate enough to perfuse their body? Well, the heart does a better job than what we can do as far as CPR. The heart does a better job at perfusing your vital organs than CPR can do. But when we look in the context of sepsis, every single patient in shock, like I told you, is usually tachypnic in their initial compensatory stage. So what does tachypnea do to your end-tidal CO2? Does it raise it up or bring it down? If you said bring it down, you're correct. As the faster you breathe, the more you blow off. And then you couple that with a patient who is not able to perfuse very well. If you don't have adequate blood flow back to the lungs, then you aren't able to adequately bring CO2 back to the lungs. So when you put that all together, a patient who is in septic shock, if they're tachypnic and have low blood pressure, they're going to have low end-tidals. If their blood pressure is low, that means decreased perfusion, which means increase in lactic acid levels. So they did there's a lot of studies supporting this, and they kind of found a sweet number for us to go off of, which is an end-tidal CO2 less than 25 or less, correlates with a lactic acid greater than 4. Remember, as I said, a lactic acid greater than 4 correlates with a high mortality rate and is what the hospital uses to base their treatment off of and tell them how sick this patient is. So then if you bring that into our criteria, end-tidal CO2, 25 or less, plus 2 or more Sears criteria, plus a suspected source of infection means sepsis alert, means that we need to activate our sepsis bundle, which includes fluid, vasopressors, and antibiotics. These are the patients that we want to target and give our antibiotics towards. We don't want to give antibiotics to Meemaw who's complaining of a cough, Meemaw who's complaining of abdominal pain. We want to target specific populations of patients, specifically those people who are in septic shock or more than likely progressing towards that way. So when we're looking at our treatment, we're going to start off with a 500 cc bolus, titrate to a MAP of 80. We can repeat up to 2 liters. Our frontline vasopressor is Levofed. Why is it Levofed? Well, because Levofed is profoundly a lot better at stimulating your alpha receptors and has very little stimulation on your beta 1 receptors. Remember, these people are compensating. Their heart rate is already up. Their strength of contractility is already up in their compensatory stage. So we don't want to give them epi if we don't have to, who is going to increase their heart rate, increase the workload on the heart. Yes, it'll increase their blood pressure, but it also will affect their heart. Levofed is perfect. It has very minimal effect on your heart rate, and it's going to help bring up your blood pressure by causing vasoconstricting those dilated vessels. Now we look at our antibiotic. Our antibiotic is going to be Cefepime. Cefepime, you are going to have a 2-gram vial. You're going to reconstitute it the same way that you would do Ancef, but instead of pushing it, you're going to put a 100 ml bag and you're going to run it over 10 minutes. So to not bore you with the microbiology behind how bacteria work and how the in-depth pathophysiology behind Cefepime, the only thing that you need to understand is that bacteria have cell walls. The cell walls help protect them. If we destroy their cell wall, it makes it easier for us to kill them. So Cefepime prevents the cell walls from being able to be formed, which makes it easier for us to kill that specific organism. What is it good at killing? So when you think about infections, the most common places that infections occur is your skin, your lungs, your urinary system, and your abdominal. Well, Cefepime is a broad spectrum antibiotic. Broad spectrum antibiotic essentially means that it can kill multiple things. So it's very good at killing pneumonia, complicated UTIs, skin and soft tissue infections, and any complicated intra-abdominal infections, which is essentially, it covers the basics of everything that could possibly become infected. Now, side effects, just like any antibiotic, it could have a feverish, it could have diarrhea, it could have a rash. It's tolerated very well by both adult and pediatric patients. When you're looking at contraindications, you need to make sure they don't have a penicillin allergy. If they have a penicillin allergy, you need to ask how bad the reaction is. If it's been a very minor reaction, you could possibly give them some Benadryl before you give them the Cefepime. If they've had anaphylactic reactions in the past to any antibiotic, but they can't tell you specifically what, or if they've had any anaphylactic reactions to penicillin, I would just hold off on giving them that. Once they get inside the hospital, they'll have multiple antibiotics beside the just one that we carry. They'll be able to tailor the treatment for the patient a lot better than we can.
So just kind of give you an idea of what sepsis looks inside the hospital. The hospital has to draw cultures, they have to start fluids, they have to give antibiotics all within the first hour. Now, just like we will be doing, they also give a broad spectrum antibiotic. But there are multiple broad spectrum antibiotics. Every hospital may use different ones or may be very specific on the doctor and what they like to order. Now, when they do draw cultures, it takes 2 days to come back. The cultures basically help the patient if they are unable to respond to the broad spectrum antibiotic and they are fighting a really nasty bug that is very resistant to multiple different antibiotics. The cultures can hopefully give the doctor some feedback onto exactly what they're fighting so they can give something specific to treat it. Now, There's going to be a lot of nurses, when they get taught in school, they're taught that they have to get cultures right away. So usually in the hospital, they don't start antibiotics until the culture is drawn. Because the thinking is that if we're giving an antibiotic, it could potentially ruin the culture that you're trying to draw. Well, I had good conversation about this with Dr. Stevens. Um, Basically, the antibiotic that we're going to give isn't going to start killing the bacteria right away. It's going to take about 45 minutes to an hour. So as long as we get them to a hospital in a reasonable time and they draw cultures quickly like they're supposed to within the first hour, it shouldn't mess up their cultures. Now, if it does mess up their cultures, that's a good thing. That means that the antibiotic that we gave worked and it killed whatever infection the patient was fighting. But this is a lot different from what the hospitals are used to, so there may be some pushback that we get from trying to start something in the field that is normally not started until blood is drawn. So it's going to be up to Dr. Stevens and Chief Taylor to go around to the different hospitals and explain what we're trying to do. Luckily, ESD48 has already laid the groundwork for us and has already been giving antibiotics to patients in the field for a period of time.
So we have a good understanding that when it comes to sepsis, the quicker you're able to recognize it, the quicker you're able to treat it, the better the outcomes. Now, when we're talking about antibiotic use and early antibiotic use, timing in sepsis, there's a lot of mixed studies. But what I can say for sure is that if you have somebody who you believe is in septic shock, who's hypotensive, who possibly has an infection, they need antibiotics. Antibiotics are warranted. Now, there's obviously risk anytime, especially for us in the pre-hospital setting with very limited ability to obtain labs, that we're going to be giving antibiotics to patients that don't need it. Now, it's going to happen. There's no way around it. There's no way that we're going to be right 100% of the time. The key thing for you to understand is that you need to understand the protocol and do your best to stick to that protocol. But also, with protocols, and especially at community, if you haven't noticed, Dr. Stevens really wants you to think for yourself. So you really need to think about what's going on with the patient and think about, do they really need antibiotics from us in the pre-hospital setting? Or does this patient just need to go to the ER, get some more labs drawn, and get a better clinical picture on what's going on with them before we're giving them antibiotics out in the field? Potentially unnecessary. But I think if you stick with the SEERS criteria and specifically start using end-tidal CO2 in these septic patients, it's really going to help you guide your decision making on whether to give antibiotics or not. So that's the lecture. Pretty straightforward. Hopefully not too much in depth. Hopefully you learned something. For those of you who are doing this online course, there is a quiz attached to the email. Please go back to the email, click on the quiz, and take it. And it lets me know that you at least sat through most of it, or at least had some form of understanding before we roll this protocol out.